Hodgkin's lymphoma was named after Thomas Hodgkins. An oma refers to a tumor, therefore Hodgkin's lymphoma is a tumor that results from the lymphoid tissues. In Hodgkin's lymphoma, there is 1 to 2% of neoplastic cells known as the Reed-Sternberg cells or the RA cells together with the normal immune cells around them. These RA immune cells cause the most of the swelling of the lymph nodes, typically leading to lymphadenopathy. Lymphomas are cancers that start in the white blood cells called lymphocytes. We have two types of lymphomas, namely Hodgkin's lymphoma and non-Hodgkin's lymphoma. The lymph system is the part of the immune system that is made up of cells called lymphocytes, which are the type of white blood cells. There are two main types of these lymphocytes: the B lymphocytes, which make the proteins called antibodies to help protect the body against bacteria and viruses. Another type is the T lymphocytes, or the T cells. Some of these T cells destroy the germs or abdominal cells in the body. Others help boost or slow activity of other immune system cells. Hodgkin's lymphoma starts usually in the B lymphocytes. The cells of origin are the germinal center beta cells and the Reed-Sternberg cells, or the RS variants in the affected tissues. Most cells in the unaffected lymph node are polyclonal reactive lymphoid cells and not neoplastic cells. We have histologic subtypes of this Hodgkin's lymphoma: the classical Hodgkin lymphoma, which involves the nodular sclerosis, mixed cellularity, lymphocyte-rich, and lymphocyte-depleted Hodgkin's lymphoma. The cause of these lymphomas is unknown, but Epstein-Barr virus may be involved in the pathogenesis of this Hodgkin's lymphoma. 50% of the Hodgkin's disease cases, the tumor cells are EBV positive. HIV infection has a high incidence. However, Hodgkin's disease is not considered an AIDS-defining neoplasm. And there is also a genetic predisposition to these Hodgkin's lymphomas. The pathogenesis of Hodgkin's lymphoma starts from the germinal center B cells, whereby it is acted upon by a transforming event such as Epstein-Barr virus, leading to development of a Reed-Sternberg cells. And these Reed-Sternberg cells lose the normal death signals known as apoptosis, and cytokines are produced that lead to the inflammatory response. The Reed-Sternberg cells represent a clonal proliferations of B lymphocytes that derive from the germinal centers of the lymph node. They consistently express CD15 and CD30 antigens. The CD30 antigen is expressed in the majority of the nodular sclerosis and mixed cellularity subtypes of Hodgkin's disease. CD15 is a mark of late granulocytes, monocytes, and activated T cells. It can be induced by a viral infection along with the interleukin-2 receptor CD25. CD19 and CD20, which are the B lymphocyte antigens, are uncommon in nodular sclerosis, Hodgkin's disease, and mixed cellularity Hodgkin's disease. Upregulation of BCL2 correlates with EBV expression. The clinical features of Hodgkin lymphoma include a painless rubbery lymphadenopathy that is on the supraclavicular lymph nodes, constitutional symptoms such as unexplained weight loss, fever, night sweats, large mediastinal mass or lung involvement, chest pain, cough, shortness of breath, or difficulty in breathing. Rarely hemoptysis is observed. Patient may present with pruritus, alcohol-induced pain at the nodal sites, intermittent fever, back or bone pain occurs, superior vena cava syndrome. The central nervous system symptoms that are due to paraneoplastic syndromes including cerebellar degeneration, neuropathy, Guillain-Barré syndrome, or multifocal leukoencephalopathy. In diagnosis of Hodgkin's lymphoma, an histological diagnosis is required: a biopsy, excisional lymph node biopsy, a fine needle aspiration that is followed by excisional biopsy if the squamous cell histology is excluded, staging laparotomy, bilateral bone marrow biopsy, and in your lab studies you conduct a full blood count for anemia, lymphopenia, neutropenia, or eosinophilia. Erythrocyte sedimentation rate will be elevated. dehydrogenase may be also increased. Electrolytes and creatinine, together with liver function tests, alkaline phosphatase, indicate a bony metastasis. Urinalysis may demonstrate proteinuria. And in your imaging, you conduct a chest X-ray for mediastinal involvement, CT scan of the chest, abdomen, and the pelvis. A mediastinal mass representing mediastinal lymphadenopathy is a very common finding, and abdominal ultrasound may be done also. We have the Ann Arbor classification of 1971, whereby the clinical staging involves the assessment of the disease by clinical examination and imaging techniques. Stage 1 denotes a single lymph node area or a single extranodal site. Stage 2 denotes two or more lymph node areas in the same side of the diaphragm. Stage 3 denotes the lymph node areas on both sides of the diaphragm. Then stage 4 denotes a disseminated or a multiple involvement of the extranodal organs. Involvement of the liver or the bone marrow is considered as a stage 4 disease. For staging classification, the spleen is considered a lymph node area, and A or B designations denote the presence or absence of the B symptoms, and these B symptoms include one or more of the following: fever, that is temperature above 38 degrees Celsius, drenching night sweats, and unexplained weight loss of more than 10% of body weight within the preceding 6 months. The spread of Hodgkin's lymphoma takes place via the lymphatics, hematogenous routes, and direct extension. Histological findings can be used to classify Hodgkin's lymphoma. According to WHO, we have 4 types of classic Hodgkin's disease. The nodular sclerosis Hodgkin's disease, which accounts for 60 to 80% of Hodgkin's lymphoma, shows a nodular pattern. The broad bands of fibers divide the nodes into nodules. The capsule is thickened. The characteristic cell is the lacuna type of the Reed-Sternberg cells, and it usually involves the mediastinum and other supradiaphragmatic sites. The second subtype is the mixed cellularity Hodgkin's disease, which accounts for 15 to 30% of Hodgkin's disease. The Reed-Sternberg cells are the classic type, which are visualized as large with bilobate, double or multiple nuclei, and a large eosinophilic inclusion like the nucleolus. It commonly affects the abdominal lymph nodes and the spleen. Patients with this histology have advanced disease stage with systemic symptoms and immunodeficiency. The third subtype is the lymphocyte-depleted Hodgkin's disease, and this one accounts for less than 1%. There is a diffuse and often appears hypocellular. Large number of Reed-Sternberg cells and a sarcomatous variants are present. It is associated with older age, HIV positivity, and patients usually present with advanced stage disease also. Epstein-Barr virus proteins are expressed in many of these tumors. In many cases of the lymphocyte-depleted Hodgkin disease diagnosed in the past actually were non-Hodgkin's lymphomas, often of the anaplastic large cell type. The fourth subtype is the lymphocyte-rich classic Hodgkin disease, and this one accounts for 5% of all the Hodgkin's disease. The Reed-Sternberg cells of the classic or lacuna type are observed with a background infiltrate of lymphocytes. It requires immunohistochemical diagnosis, and some cases may have a nodular pattern. Clinically, the presentation and survival patterns are similar to those of the multiple cellularity Hodgkin disease. Nodular lymphocyte-predominant Hodgkin lymphoma. This is not a classic Hodgkin disease, and it accounts for 5% of all the Hodgkin disease. The cancer cells in the nodular lymphocyte-predominant Hodgkin lymphoma are large cells known as popcorn cells, which are variants of Reed-Sternberg cells, also known as lymphocytic and histological cells, that's in lymph nodes in the neck and under the arm. It can occur in people of any age and is more common in men than in women. This subtype tends to grow more slowly and is treated differently from the classic types of Hodgkin's disease. The treatment of Hodgkin lymphoma: patients with early stage have a better outcome if treated with chemotherapy and adjunctive radiotherapy. We use the ABVD regimen, including doxorubicin, vinblastine, bleomycin, and dacarbazine, followed by radiotherapy of the involved lymph nodes. Treatment response is assessed clinically and by repeat CT scan and a PET scanning. Patients with advanced stage disease are managed with chemotherapy alone. As with early disease, initial PET negative remission predicts a long-term remission. Cure rates are lower in advanced disease, and patients with resistant disease may be considered for an autologous HSCT, that is the hematopoietic stem cell transplant.